So what we're going to talk about, like Dr. Lewis mentioned earlier, there are some newer alloys that are coming out. And the question is, are those going to be beneficial? Is it going to change the way, are there alloys out there that can potentially change the way that we have been addressing these long cases, these complex spinal surgeries? You know, we've had first stainless steel and titanium and cobalt chrome, and those have been the three alloys that have been out on the market for a long time. And when you look at the pseudoarthrosis rate on these cases, and depending on which article you read, it's anywhere between 9 to 22, even up to 40%. So that's pretty impressive when you think about. That's not. Oh, okay. Thank you. So that's pretty impressive when you think about 1 out of 10 or 2 out of 10 cases that we do, depending on how well we do it, the rod's going to fail. So the solution, as we've been talking about, is to go on to the multi-rod constructs, 3 and 4 rod constructs. Well, even with that, this is the Linky article Hassan published this year, like a month ago, and showing the benefits of going from a 3-rod to a 4-rod construct. Do we reduce the rate, the failure rate, after a couple of years? And we do. Essentially, they halved it. It went down from 28 to 14% or 15%. They didn't show a change in revision rate, but that's still quite a bit. With a 4-rod construct, to think about that 15% of these rods are going to still fail. And when you think about the European article, again, just a couple of months ago that came out, they looked at well-balanced, well-aligned, multi-level constructs, and they found that the 4-year data outcome, they had almost a 40% failure rate, with essentially 14 of those cases breaking down above a PJKs, 20 cases that with rod failures. Now let's think about that. These are top world-renowned surgeons that are at the top of the game, and we're showing that there's a 40% failure rate on some of these cases. That's pretty scary, especially when you think about other fields, i.e. NASA. How can we take a spaceship, a rocket, and send it up into the air at these mega speeds, huge amount of vibration, huge amount of heat, and those rockets aren't failing? Yet we have essentially a person, we're putting 2 rods in, 4 rods in, and when we compare that to a rocket, really low demand patient, yet we're showing 20, 30, 40% failure rates. So we know it's not the surgeon. I mean, we got in Europe, in the United States, top surgeons were showing these rates. We know it's not the osteobiologics because all these data show multiple osteobiologics. So the question comes down, is the alloy there? Is the alloy the adequate alloy, or can we do better than what we have? So when you look back at the history of NASA, and you look back, when did they start using this alloy? Because molybdenum and rhenium came from aerospace engineering. So back in the 60s, they started looking at molybdenum. And more is M-O-R-E, more, those are the periodic numbers. Both of these elements are low in the periodic table, number 42 and number 75, versus cobalt, chrome, titanium higher up. So in the 60s, they started looking at molybdenum. Why? Because essentially their melting point and their strength. They found that they had a nice solid strength in that alloy. Then in 1972, NASA combined molybdenum and rhenium, and started showing that, hey, we have nice ductility, and the strength on these things were even better by combining the 2 alloys. Then in the 1990s, they started using them on the thrusters to get these heated elements, and they weren't failing as much. They were doing very well with them. And so finally in 1998, they used the first combustion thruster to go in space with a combination of the more elements. So the key, according to NASA, was the rhenium. Rhenium has a very high fatigue rate. That rhenium is it's hard to fail, according to NASA, when you read a lot of the articles. So the fatigue resistance is very, very high. So when you combine that with molybdenum, that has the strength, and the rhenium, they found that they could send up these rockets at loads exceeding temperatures of 3,000 degrees, extreme cyclic loading as they're going through and coming back with very low failure rates. So they've essentially proven the test of time. Extreme cyclic loading, oxidation, thermal fatigue, and over temperatures of 3,000 degrees Celsius and not failing. So we as surgeons have to say, hey, if they can do that, can we apply that to spine? Can we do better than a 20, 30, or 40% failure rate that we're seeing now? So this is the goal. This is the looking at the when we ask the key questions here, like when asked today, I mean, is 20 to 40% of failure rate, would that be acceptable in spine? Obviously not. I mean, that would be very concerning. Would more and alloy reduce failure rates in our long, complex spine cases? Well, the data is encouraging. So when you looked at that, they started doing in lab studies and looking at the combination and comparing that to cobalt, chrome, and titanium. And you can see that the fatigue life, let me go back to this one here, the strength life of the two alloys combined is well above, like Dr. Lewis was saying, we're looking at the stress and the strain and the stiffness curvature, and you can see on the far left, that's going to be your curvature looking at the force and displacement. And when you look at the more alloy, is much higher than the titanium and the cobalt chrome, and the same on the stiffness one. Now on the stiffness curvature on the right, that's comparing 5.5 rods, but because of the stiffness of the rod and more alloy, they realized that they don't need a 5.5 rod, and they actually dropped to a 4.5 millimeter rod. So now what's in the field is actually a 4.5 more rod versus a 5.5, because a 5.5 would be way too stiff to be put in humans. As you can see, it's much stiffer than a 5.5 cobalt chrome rod. When you look at the fatigue life, they took the more alloy out 10 million cycles without this thing failing. Okay, compared to the failure rate of cobalt chrome and titanium, which was much lower. So this is the key here, and basically the biocompatibility. We know that the microparticles in cobalt chrome is toxic. It's well above, if you look at especially European literature, is well above the FDA-approved rates. The permitted daily exposure is 914% higher. Titanium 47%. Molybdenum, rhenium, well below the permitted daily exposure rate. So with that, the FDA approved the more alloy back in 2019 due to its superior strength, fatigue life, plastic deformation, and essentially the low ion release with low cytotoxicity. Plus the fact that there's no nickel in molybdenum and rhenium alloys compared to the cobalt chrome and titanium. And when you combine this, we know that the general population have a 10 to 20% hypersensitivity to nickel. So that's a big breakthrough. That led to the study that I was the lead author. And essentially, this was a study we presented back on CNS and IMAS a couple years ago. What this was, it consisted of 10 spine centers throughout the United States. The only inclusion criteria is that you had to have more than 4 levels of fusion above the age of 18, and at the time, a 6-month follow-up. When you looked at the data, this is a 2-year data post-op, so there was 6 months to be inclusive. This is a 2-year data. 159 patients from 10 separate spine centers in the United States with 0 rod fractures, which is pretty impressive when we look back at 10 to 20%. Especially when you look at the bottom here, that 39% of these patients had some type of PSO or a Smith-Peterson. So roughly 40% of them had a osteotomy. That data now is up to 36 months, and there still has not been a rod failure in that initial group. So this is one of my patients. This is a gentleman, 61-year-old male. You can see it with a flat back, had prior spinal surgery. You can see his imaging studies there. We went in and did a 3-column osteotomy, and you can see this is a 4.5 millimeter rod, temporary rod there on the left side, and then you can see, and here he is. This is a 3-month follow-up, T10 to the pelvis with 2 4.5 millimeter rods. Okay, this is his 3-year post-op standing image. What also happens with we kind of talked about those bends earlier on some of these rods. We know when you take a rod bender, you start bending that rod, or when you put the cap screw and you tighten it down, you compress it, you retighten it, you're notching the rod. So are those a nidus for fatigue? Are those a nidus for failure? And we think it is. It has to be proven, but we can assume that causes some weakness in the rod. So when you looked at the refractive to notching, and when you look at these rods in the three-point bending test, you can see how cobalt, chromium, and titanium fail at much lower loads versus the Moore rod at the top, the blue one, didn't fail. They took it down to 14 millimeters, didn't fail. Then they went out and they took that rod and they notched it, they nicked it, and they took 50% of the rod out. They cut 50% of the rod and they put it back on this test and it still did not fail. So that says a lot for this rod. That allows us, this is one of my cases, to do these type of crazy bends in a rod. I would not have done this with a cobalt, chrome, or titanium rod. But you can see this crazy bend that I'm putting at the bottom. And that's in August of 22, September 22, 6 weeks follow-up. And this is almost 3-year follow-up here on the right side. And you can see how that's holding pretty nicely. Look at this. This is a 68-year-old female, severe osteoporosis. That's her preoperative when she was referred to me. And you can see that transition breaking down. You can see how her bone quality. She has bilateral hips, bilateral shoulders, a prior ACDF. Very, very poor bone quality. And you can see the postoperative images 3 years post-op with the 4-5 Moore rod in there. And low levels of all of these, look at the top, there's a very low level of PJK that we've been noticing. So what they did with that alloy, because of that alloy, you can make it smaller, so without sacrificing this, you lower the stiffness, but you don't sacrifice the strength. So they were able to use this and put this into the link system. The link system of the expandable cage is that part that opens up there. So they can make, with a smaller link, they were able to put these expandable cages down to 3 millimeters and up to 16 millimeters, which gave us 23, or not us, gives them 23, gives us as surgeons 23 degrees of lordosis. That has changed in my practice on some of the cases that I've done. I've been able to back off on some of my PSOs. This is a case that came in, it was referred to me, and had a prior expandable for a T12 burst fracture. You can see it has minimal lordosis, inability to stand straight. So the plan for me was to go in there, I was going to do a PSO on this case. And you can see that they had put a prior cage in at the L5 level and subsided down into the vertebral body. So I was able to go in there and sneak one of these expandables above that pseudo rate, break down, took that fibrous tissue out, put this expandable cage in there, put a second expandable cage in there, and you can see the lordoses that are restored and was able to avoid a PSO. So great amount of lordosis on those expandable cages because the link system is so small that they can put it in there and not sacrifice that space in there. Here's another case that I showed that, sorry about that. Another patient that had a couple of systems dominoed on top of each other. You can see the bone quality, once again, a pain stimulator, multiple kyphoplasties. Just in a lot of pain here, you can see the scans on the side. And we came in there and I essentially put another expandable that recreated more lordosis on this patient and took them up, put the screws through the bone cement and was able to restore. This is 2.5-year follow-up. Again, severe osteoporosis. If I put a stiff rod in this patient, I would probably get a PJK. But we're not seeing, in general, the 10 centers, we're showing a reduction in the PJK, and I could explain to you why we think that is. But here's another case here that had multiple raw constructs. They just keep adding more systems on top of each other, but not fixing the underlying problem, is that we had to get the lordosis. So we took this patient, or I took this patient back. You can see the top of the construct breaking down. So went back in there, did another PSO expandable, and you can see, or that's not expanded, just a PSO at that level. And you can see I took that patient up. So, and here you got the pre and the post, several years out now in this case. All the cases I'm showing are a minimum of 2-year out post-op images. So here's another 56-year-old with some coronal sagittal balance. This is my longest patient out, that's why I'm showing this one. and you can see the PSO. The other beauty about this is, again, as opposed to putting more hardware in, which creates two problems in my view. Number one is less bone mass, space for bone graft. Again, we want to get the bone fusion. So if we have smaller rods, we could put more fusion material, biologics, whatever you want to use. And then number two is less metallurgic reaction. Again, we don't want to see all that cobalt chrome breaking down in the body. So if we can minimize hardware and increase bone graft, I think it's a win-win for the patient. And so here you can see, and this patient is at the 4-year post-op. And you can see with a little offsetting, I did an offset PSO in this patient, correct the coronal and the sagittal balance to restore that height. So 4 years post-op on that patient. Here's another one with multiple kyphoplasties. Again, bone quality is horrible on this patient, and you can see there, went through those, and here you can see the post-operative images right here. The pre and the post. So, well, let's push the limit. Now we're going to say, okay, well, can a 4 or 5 sustain a heavy-set patient? And so this is a patient 69, 270 pounds, and you can see they have a vascular graft up front. They're kind of worn down in the backside there. You can see the graft. So I really didn't want to go to the front on this patient. So we did it all through the backside on this patient, and you can see the two expandable. Didn't get a lot of height on the bottom one, got more height on the top one there, and you can see the fixation right there. 585 pounds. Now, obviously, I wouldn't do this patient normally, but I got calls from the pain doctors, the primary care doctors. I was trying to get the patient to have a gastric bypass. They did not clear the patient to have the surgery. So instead, we said, we got to get him moving. And he's a nurse at a local hospital. Could barely even move anymore. So who's going to win here? You know, the table going to crash because the table also had a 500-pound limit. So I was a little concerned about that. So, and here you can see the post-operative images there at 3 years out. Became more active ambulatory. And then after the surgery, they actually approved his gastric sleeve after we fixed him and he started moving more. So, but we did it when he was at that weight, and here you can see his post-op 3 years out. So in conclusion, when we're talking about it's an option. You know, it's an option. I'm not saying it's alloy to go to, but it's an option that I think we need to start looking at. There's got to be other alloys that we can do, because I don't think it's acceptable to have 20, 30, 40% failure rates when we're doing such great surgical procedures with all these surgeons out there. So this alloy provides a 4.5 millimeter rod. It's proven 3 to 4 years. Obviously, that's not a long time yet, but we're out 4 years on our data that we have. So far, no rod failures in that initial study that we have with the 10. And we're showing a reduction in the PJKs. That has not been published. It's probably going to be published in the near future. It's a superior strength. Fatigue life has been shown to be improved, and the biocompatibility is key. I think that's a big thing that, reducing those ions in the human body is going to be, and plus number 2 is there's no nickel in this alloy. And we don't really know and understand the whole side effects of the nickel toxicity or hypersensitivity that patients have. This is some other stuff. Because of that, they've been able to go to a lower cervical system. We talked about the inner body. This alloy came out initially because of the heart for the TAVR. That's what they were targeting at. But because they started seeing the benefits of it, they kind of addressed the spine and they addressed the foot and ankle. So I'm just showing the spine components. But thank you.
So thank you for the lecture. Obviously a very exciting new technology. You are part of these early adopters, and sounds like it's a multi-center group kind of bringing forward these, kind of now getting into long-term follow-up. What have you seen, any failures? And if so, where have they been?
Yeah, so interesting. Initially, we were seeing screw failures on my cases. And then I talked to some of the colleagues, and they saw screw failures, which was like, oh my gosh, this is a big problem. But it's actually showed the promise of the rod. Instead of the rod failing, it was a screw failing. So this particular company addressed that. They fixed the screw component of it, so that has dropped down. And then I did have one rod failure. I had that recently, around 6 months ago. And I was doing a case, and it was a revision case with this high-grade spondy at L3-4. And I think I got a little too pushed, and I did a single 4-5 rod at that point. And then I did plift that case, but I probably should have reinforced that rod at that point because they had already failed once. I brought them back. I pliffed it. They didn't put any interbody. I put 2 interbodies with a 4-5 rod just at that one level. But thinking because all these other ones never failed, I never bothered. But I just fixed that one and went back there and fixed it. And I just put a little 2-rod construct just at that one level, right at that section. But.
Steve, I think you're presenting some really important data in terms of long-term follow-up. This material is exciting, and your data is encouraging. I understand why you're not getting rod breakages because the ultimate tensile strength of the rod is better than certainly titanium and cobalt chrome. But how do you explain if this is stiffer? How do you explain the reduced PGA-K rate?
Because it's more ductile. The one thing that they were even emphasizing, especially when you look at the data from NASA, is the ductility of the rod. And if you put in a 5.5 rod in, okay, I would never use a 5.5 more rod. It would be way too stiff based on those graphs up there. So you really have to drop it down to a 4.5. And even anything, I even talked about going lower than a 4.5. But if you do a 4.5 rod, that's been shown to be 10% less stiff than a 5.5 cobalt chrome. Equivalent to a 5.5 titanium rod, 10% less stiff than a 5.5 cobalt chrome rod. So it's actually a less stiff rod than a 5.5. So a 4.5 is less stiff than a 5.5 cobalt chrome. Make sense? But it's also more ductile. So when you put this rod in, you will see it actually slightly bend. Like if you use a rod reducer, I showed that one time in the lab here, and you have the rod and you reduce it down, you'll see the rod give and kind of fit into the saddle of that screw. And you don't see the plowing. You know, if you have a stiff rod and you go to put a reducer and it's osteoporotic bone, a lot of times, as you guys I'm sure aware, you'll see the screw plow out right of the pedicle. So that's a rare finding because you see it kind of gives in a little bit.
Thanks so much, Steve. So the tulip heads on the screws that you're using, those are not the same metal?
No. The screw is not, the only thing that is, and that's with this system here, the only thing is the rod. It's not the screw.
Okay. Is there any galvanic reaction between the tulips?
No, they're not seeing a galvanic reaction. That was a concern initially, but we're not seeing the galvanic reaction in our studies. And when you look at the lab data, not seeing that cross-reactivity.
Okay. Have you used other screws with these rods?
I have a case coming up soon. I'm going to be actually Tuesday, not next Tuesday, the following Tuesday, I'm doing a cervical thoracic, and I'm going to be dominoing a cervical onto a Moore rod. So a cobalt chrome onto a Moore. I don't want to take the whole cervical down. I'm just going to domino it in. But I have done that before. I have dominoed other systems onto this. I just have to get a 5.5 to a 4.5 domino. Yes.
Yeah, I had a question regarding the benders you use. Do you use iron benders or a French bender currently? And you have a lot of experience bending other rods. What does it feel like in diameter and the common rods that we use? Does it feel like bending a 6.0 cobalt chrome, or is it harder than that?
That's a very good question. That's a very cool. Regular benders. And it's actually a much softer. When you bend this, it's not hard. You'd think it'd be very stiff, like very hard to bend down. It's not. It gives in when you try to bend this rod. So, and I had the fellow bend it last time here, and he was surprised when he put it in. He was bending it, and there was a video also where people have talked about that we made here, where we kind of bend the rod, had the fellow bend the rod in all different angles. So it's not a hard rod to bend. I mean, you would think it would be based on these numbers, but it's not. It actually bends pretty smoothly. So just a regular bender, and then I use my sagittal. And then when I have the rod in situ, a lot of times I'll just have to use my sagittal benders, to get it in, because I want that rod to drop into the head, because I don't want to pull it out. I want to watch for PJK. So I just kind of bend it down, and it sits very nice in the saddle. So.
Well, thank you so much.
Excellent. Thank you.
So I think we are just about